Atypical Acute Gonorrheal Urethritis. The good or evil fortune of the patient in his choice of a physician, as well as in his reaction to the disease, so influences the course of each individual case of gonorrhea that the attempt to separate typical from atypical cases, though justified by expediency, has no foundation in clinical fact. The above description of a typical acute gonorrheal urethritis describes many cases in general, but none in particular. Every case is actually atypical to a greater or less degree. Prolonged or complicated cases. What proportion of gonorrheics become chronic? I do not know. In the clinic, most cases approach the 3 months limit and perhaps half surpass it. In private practice, by the aid of repressive measures, we get better results. But practically every unrepressed case of gonorrhea is a, quote, complicated case. Some one of the complications mentioned below almost invariably arises unless repressive measures are employed. Mild cases. The initial gonorrhea is quite invariably severe. Subsequent infections, especially if often repeated, may run a much milder course. So mild, indeed, that it might be quite impossible to determine when a given patient was last infected. The bearing of this fact upon the alleged persistence of gonococci in urethral pus for many years in exceptional instances is most important. Reinfections may excite merely a slight mucopurulent discharge with the least possible subjective irritation. The acute attack may last but a week or so. Yet from such an infection, gonococci may persist in the urethra quite as long as though the attack had been most severe. Moreover, the urethra thus inflamed may resent instrumental or other traumata, though the reaction to these is not so fierce as when the urethral inflammation is more intense. Acute reinfections. Sharp, short reinfections of the anterior urethra with copious creamy discharge, yet lasting but a few hours or a few days, are more often due to reinfection from the patient's own secretions, occasioned by instrumentation, sexual or alcoholic excess, spontaneous rupture of follicular abscess, etc., than to fresh infection acquired from without. The striking feature of such reinfections is their brevity. The contrast between the profuse, creamy, gonococcus-laden discharge of today and the entire absence of all symptoms tomorrow. Severe cases. Urethral gonorrhea may be severe in its onset, prompt involvement of posterior urethra or epididymis, early appearance of complications, intensity of subjective symptoms. In its complications, or in the severity or duration of its acute symptoms. Thus, chordee, or the pain and frequency of posterior urethritis, may be almost or quite the first symptoms complained of. Epididymitis, even, may apparently begin the attack. Yet, unless they be auto-reinfections, it is not correct to classify such outbreaks as beginning in the posterior urethra or in the epididymis. The prolongation of intense chordee or posterior urethritis through many weeks occurs just often enough to remind us of the total lawlessness of gonorrheal inflammations. Cases modified by treatment. The local treatment, now almost universally employed throughout acute gonorrhea, always materially modifies the course of the disease. If successful, it ameliorates all the symptoms and minimizes the danger of complications. If unsuccessful, it intensifies the urethral inflammation, excites complications, or encourages chronicity.